series. Now we're going to continue talking about ECGs, how you could diagnose myocardial infarction on an ECG, and which site is being involved, and also the culprit artery involved. Now for the criteria of ischemia and acute coronary syndrome, you would need an ST segment elevation in at least 2 contiguous leads, and the elevation has to be more than 1 millimeter, so 1 little square. Usually we have in our emergency departments the 12-lead ECG, and you should perform it within 10 minutes. Now sometimes you find other changes such as ST depression, T wave inversion, Q waves. These are also indicative of ischemia and acute coronary syndrome. Sometimes some presentations are not conclusive and the ECG does not show or diagnose acute myocardial infarction, so you can repeat the ECG to find it. Now for the blood supply of the heart, you've got 2 systems, the right coronary artery right here and the left coronary artery. So the right coronary artery, which then divides into the marginal branch and the posterior descending artery. And it basically supplies the whole right coronary supplies the right ventricle, the conduction system, and the inferior part of the left ventricle. And that's because of the posterior descending artery, which supplies the posterior and the inferior walls. While the left coronary artery, it gives the circumflex branch, which supplies mainly the lateral walls, but also part of the anterior wall and part of the inferior wall. And it also it gives us the main branch, which is the left anterior descending branch, and that supplies the anterior wall and part of the septum as well. Now of course the left coronary artery also supplies the conductive system. Now this mnemonic helps us, it's called the PALE mnemonic. It helps us to, when we're dealing with ECG, to look at different contiguous leads. So when you have suspicion of a posterior MI, you actually look at the anterior walls, exclusively V1 and V2. You look for reciprocal changes. When you have ST elevation in the anterior wall, to confirm the reciprocal changes, you actually look at the inferior, so with A with the I, inferior leads, and then the inferior wall ST elevation, you look at the lateral wall for reciprocal changes. Now this table actually summarizes a lot, and it tells a lot about all of the leads that include which wall and the artery involved. So let's start off with the septal. So the septal leads V1, V2, and the most likely culprit, of course, as we said, the LAD supplies the septum. So you would find ST elevations in V1 and V2. Now without reciprocal changes. The anterior leads include the V3 and V4, could include the V2 and the V5. Of course, you would find reciprocal changes in the inferior leads according to the PALE mnemonic. And also again, the LAD is responsible for supply. The lateral leads, V5, V6, the reciprocal is going to be in the inferior, and the lateral is mainly supplied by the circumflex. High lateral, 1 AVL, 2, 3 AVF reciprocals, and the LAD is going to be the one supplying the high lateral wall. The inferior, now the inferior has actually 2 supplies, the RCA and the circumflex, and we're going to talk about how to differentiate between the 2. Now you'll find, of course, ST elevations in leads 2, 3, and AVF. And the anterior septal, V1 to V4, the reciprocals, of course, are in the inferior leads, and you would use the artery to supply as the LAD. The anterior lateral, again, V3 to V6, including also one in AVL, which is the lateral part, and the reciprocals would be in the inferior. So an anterior lateral MI would be an occlusion in the lat. An inferior lateral one is of course 2-3 AVF with the laterals V5 and V6, and the culprit artery is the circumflex. Now in a right ventricular infarction, you would find, you would actually look at leads V1 and V2. You would find an ST elevation in those. And also you would find sometimes an extending infarction to the leads 2, 3, and AVF, which are the inferior leads. And that's because the RCA actually supplies the right ventricle and the inferior wall, as we talked about in the supply of the arteries. Now the posterior wall, we said in the beginning on the pale mnemonic, when you want to look for a posterior MI, you look at the anterior wall, so the V1, V2, and you would actually find an ST depression. And we'll talk about why later. Now of course the artery, RCA or circumflex. Now there are causes or conditions that cause ST changes, ST segment changes, repolarization changes in the ECG, but are not due to myocardial infarction, and they are all listed here. So basically any damage, any change to the velocity of the myocardium in electrical impulses can cause this. So it's important to note these conditions. I'm not gonna say them all, but take a look at them and put them in mind, because they could mask an acute myocardial infarction, or perhaps cause a false positive. Now this is a summary again of the leads. This was the one we talked about, the posterior MI. So we said in the posterior MI you would look at the anterior wall. And the reason is, for example, if there was a posterior MI, there would be an ST elevation in posterior leads. But we don't have posterior leads in a classic 12 lead ECG. So what we do is we look at the wall in front of it, which is the anterior wall, and instead of an ST elevation, you would have an ST depression. And instead of a T wave inversion, you would have an upright T wave. And instead of a Q wave, you would actually have a pathological R wave. And this all happens in V1 and V2. Now, a point is, whenever there's a conduction block, so a left bundle branch block or a right bundle branch block that's new, so not present in a previous ECG, the culprit artery is the LAD most of the time. Now, an inferior lateral MI could involve the posterior wall, and that's why when you have an inferior lateral MI, you gotta check the V1 in case there might be posterior wall extension. Now, coming up to this first ECG, you would look here and see that there is an ST elevation in lead 2, lead 3, and AVF, which are inferior leads. Now, that means that this is an inferior MI, but you gotta also check the lateral leads, see if there is an ST elevation in any of them. V5, V6, there's none. AVL and lead 1, there is no ST elevations in the lateral leads. So therefore, this is just an inferior MI, and the culprit could be either an RCA, right coronary artery, or the circumflex. And to know that, you have to actually look at lead 1. If there is and this picture explains it. If there is an ST depression in lead 1, then it's an RCA artery. So basically, the inferior wall of the heart is supplied by two arteries, the right coronary and the circumflex. 80% of the time it's the right coronary artery, and 15% of the time it's the circumflex. 5% of the time it's actually codominant. Okay, so you will look at the ST elevation and in lead 1, if there is an ST depression, it is an RCA. And the reason for this is this is lead 1 and it's going towards the left of the heart. So an ST depression would be something away from it, so to the right side. So that means there's a pathology on the right side of the heart. So that's why it's indicative of an RCA. However, ST elevation means that it's towards the lead 1, towards the left side. So then it's probably a circumflex pathology, and pathology right here on the left side. Sometimes lead 1 is actually isoelectric, so you actually use leads 2 and 3. And again, the same idea, lead 3 actually goes towards the right side. So if lead 3, ST elevation on lead 3 is more than lead 2, then it's towards, pathology is towards the right side, and therefore it's an RCA. If the ST elevation is more in lead 2 rather than lead 3, and the lead 2 actually goes towards the left side of the heart, so that means the pathology is on the left side. So that would mean that the supplying artery to the inferior parts is mostly the circumflex. Now, looking at this ECG, you actually can see that there is ST elevation in leads 2, right here, 3, and AVF. Now again, we have to look if there's an inferior lateral extension. So V5, V6, there is nothing. There is no Q waves, no ST depressions. Lead 1, you actually can see in lead 1 there is ST depression, and also in lead AVL right here there is an ST depression. So that's because of the reciprocal change. According to the pale mnemonic, you want to look for reciprocal changes. If it's an inferior ST elevation, you look at the lateral leads, and therefore this is an inferior myocardial infarction. Now again, you want to see if this is an RCA or a circumflex. You look at the lead 3, and you can actually see that the ST elevation on lead 3 is more than lead 2, so this is probably an RCA. Now this is another ECG, again lead 2, 3, and AVF. You check the lateral leads, and you can see that there is ST depression in AVL, lead 1, V5 and V6, not there, V6 is not apparent, so there is reciprocal change. But again, you also, after looking at the lateral leads, you also have to check the V1 and V2, because with an inferior MI, you could have, it could be that this is not an inferior MI, but a right ventricular infarction. So you would look at V1, and you actually can see that there is a Q wave right here and an ST elevation. So in this case, this is actually a right ventricular infarction because of the ST elevation. So what you do is you put your leads on the right side of the chest, V1, V2, V3, and V4, and you can actually see there are ST elevations in all these leads, and confirming the diagnosis of a right ventricular infarction. Now, this is another ECG. Here you have V1, V2, V3, ST elevations in these, V4 as well. So this is an anterior MI. Now you would look for reciprocal change in the inferior leads. So 2, 3, AVF, there isn't any. So this is a pure anterior wall MI without reciprocal changes. Again here, you have V1, V2, V3, V4. So it's an anterior MI, ST elevation. And then you look at the inferior leads. You do see that lead 2, 3 and AVF show ST depression, so a reciprocal change. So the reason why the previous ECG did not show reciprocal change and anterior MI, this one showed anterior MI and reciprocal change. So the reason is why, because the culprit artery in both is the LAD, but here, because the damage is more, the occlusion is more proximal within the artery, damaging more tissue. So that's in the previous ECG, the occlusion was more distal without reciprocal changes. So this brings us to the notes saying the more leads involved, the larger the amplitude of the ST changes, the more extensive and severe the occlusion is. Now this ECG is another one. You can actually see that in the V1 you do have an ST depression, and in V2 you have an ST depression. So looking at the leads, AVF, that's an ST elevation. Now this picture is actually a posterior wall infarction, because as we said, in V1 and V2 you want to look for the mirror image of an ST elevation. It's because V1 and V2 give you the picture of the anterior wall. This means that there is some pathology going on in the posterior wall, and as we said, you would find an R wave, an ST depression, and an inverted, an upright T wave, Okay. So from these ECGs, with an inferior wall ischemia, like ischemia in leads 2, 3, and AVF, you always want to check for the lateral wall, because then there could be an extension and it would be called an inferior lateral wall ischemia. And you would also look at the posterior wall, because sometimes an inferior lateral MI could extend to the posterior wall. Or even the right ventricle, it can have a right ventricular extension. So there could be involvement of the right ventricle. So you'd look at V1 and V2. While in posterior wall, of course, you would find the ST depression, while in right ventricular extension, you would find ST elevation in V1 and V2, and you would put more leads on the right side of the chest to confirm it. Now this is the end of this part of this lecture, and in upcoming lecture we'll be talking about troponin and its clinical significance and how it can help us in clinical scenarios. Thank you.